My case is a 32 years old woman with history of palpitation. Started at the age of 17 years old. These palpitations of sudden onset and offset and associated with dizziness. The patient had multiple ER visits to terminate this tachycardia via IV medication. The last attack was terminated successfully via 6 milligram IV adenosine. General and cardiac examination revealed no abnormality. Echocardiography showed normal heart. We can see the 12-lead ECG, the normal resting ECG, normal PR interval, normal QRS complex, and normal QT interval. No signs of any manifest or subtle pre-excitation. This is the tachycardia ECG showing another complex tachycardia. I will demonstrate now via the marker. We can see here the inferior leads with pseudo S wave. Here in lead 2 and AVF. The chest lead V1 showing a pseudo R, which means that it's most probably an AVNRT, which goes the first in the differential diagnosis of this case. In the EP lab, utilizing the conventional GE's PROCA EP recording system and Stuttgart ablator, the procedure was done under local anesthesia, sterilization, and local infiltration using lidocaine. We used a quadripolar 6 French catheter via right femoral vein, punctured to the Hess boundary region under fluoroscopic guidance, and a 6 French decapolar catheter introduced via the right femoral vein to the coronary sinus. Also used a 7 French ablation catheter, non-irrigated 4 millimeter catheter via the right femoral vein to the RV via a long sheath 8 French, which is a Mollin sheath. A filtered bipolar intracardiac electrogram were recorded. Atrial pacing, extrastimulus, ventricular pacing, and extrastimulus was performed during using the right atrial and RV catheter. A 12-lead ECG recorded before, during, and after the study, and we used 5,000 international unit of heparin IV after catheter placement. Here the 12-lead ECG at the EP lab. We can see a normal resting ECG. Here, after placement of the decapolar catheter, the CS catheter, which is arranged from distal to proximal, and the Hess catheter, which is a quadripolar catheter, which is arranged also from distal to proximal. And we choose 3 leads representing the 12-lead ECG, which is lead 1, AVF, and V1. Here we can see a sharp A on the decapolar catheter and a far field V. In the Hess catheter, which was placed in the RV, we can see a V wave, which is goes along with the QRS complex of the ECG. We start to navigate.
The third beat, Salah, the third beat shows AH and V.
Yes, I was telling that we navigate the quadripolar catheter. We pulled it back with a slight clockwise rotation to obtain the Hess deflection at Hess region. We can see here AHV. It is the side of the Hess region to start the EP maneuvers of our patients. Ventricular pacing here showing 1-1 VA conduction. With concentric activation, earliest retrograde A was at the Hess catheter. As we can see here, the earliest A at the Hess catheter, and a concentric activation in the CS decapolar catheter from proximal to distal. Here, ventricular extrastimulus showed decremental conduction via AV node. We started to do atrial extrastimulus. The atrial stimulus showed AH jump and the echo beat, which are at 450 pacing cycle length, and extra stimulus at 230 milliseconds. We can see the H jump and one echo beat. This resulted in the tachycardia, which is most probably AVNRT, slow, fast, typical AVNRT, which induced by atrial extra stimulus with a tachycardia cycle length 346 milliseconds. We did a ventricular overdrive pacing, which showed a PPI minus tachycardia cycle length equals 250 milliseconds. We can see here the ventricular pacing capturing with the QRS complex and entraining the tachycardia. Here the pacing cycle length was 280 milliseconds, and the AA also 280 milliseconds, which means that the ventricular overdrive pacing entrained the tachycardia greatly. And this is the post-pacing interval, which measured 590 milliseconds from the pacing from the ventricle to the returning signal on the pacing channel, which is the distal Hess catheter. Here we started, after induction of tachycardia, we started ablation during tachycardia. We can see here the ablation artifact on the ablation channel. We started ablation during tachycardia, which was successful and resulted in termination of tachycardia. And after that, we can see a frequent premature atrial contraction conducted, and we stopped here. We tried to induce tachycardia again via atrial extra stimulus, which resulted in also AH jump and echo beat and one tachycardia beat. So we decided to ablate again, but this time on during sinus rhythm. We can see again the ablation artifact on the ablation catheter with a very good signal on the ablation catheter, very good V versus A with a ratio with 5:1, which is the slow pathway state. You can see here a sinus rhythm during ablation with a PEC, which is conducted. We started to see here a stable slow junctional rhythm during ablation, which means that we doing great during the ablation. Here the slow junctional rhythm, and we stopped at this base, which is the artifact on the ablation catheter after we stopped the ablation. And we can see also a stable junctional rhythm over the whole window. Here the ablation, after stoppage, even after stoppage of ablation, we can see a stable junctional rhythm and return and the resumption back of the sinus rhythm after finishing of the junctional rhythm. Post-ablation study, we now can see atrial extra stimulus, which used to generate and induce the tachycardia was here refractory. We can here see the pacing cycle length and the extra stimulus without any AH jump, and we can see the refractoriness of the atrium in the atrial extra stimulus, which at the same cycle length used to induce the tachycardia. Again, we used only a slower speed on the screen to see the refractoriness on the atrial channel after doing atrial extra stimulus. Ventricular pacing was used again, but it showed a VA conduction. Here we can see also at a slower speed 100. VA 1-1 conduction, which means that the ablation didn't affect retrograde conduction of the fast pathway of the AV node. This is the ECG at the end of successful ablation of typical slow fast AVNRT. Now we will see the side of ablation, the floor side of ablation here. The slow pathway هنا
Salah,
Okay.
take your time to explain the catheters because they did not see the catheters in the first basic study. So ask
Okay.
every catheter, what does this mean? The
Okay.
quadripolar, the betapolar.
This is the REO view. We can see here the CS catheter inside the CS body, which is a posterior structure. Also, we can see his catheter at his region, and we can see the 7 French ablation catheter 4 millimeter non-irrigated catheter via the long sheath here at slow pathway area. In the LAO view also we can see the successful ablation site. We can see the CS inside the decapolar catheter inside the CS body and the HIS catheter at the HIS region and the ablation at the slow pathway at the posterior triangle of Koch via the long sheath here. Here we can see the AV node re-entry tachycardia mechanism. Here the atria, here's the ventricle. We can see the dual AV nodal physiology, the fast and the slow pathway. This is a slow fast form of AVNRT, which is the most typical AVNRT. If we can see here the propagation of tachycardia, the slow fast tachycardia. If a PEC come, it find the fast pathway refractory and the slow pathway lost refractoriness, and it conduct via slow pathway, which is represented in the intracardiac as AH jump, and return it back to the atrium via the fast pathway, which represented as the echobeat. And it goes like that, slow, fast, slow, fast, slow, fast.
Okay, Dr. Anwar, are you ready to share your screen about the mechanism and the physiology of the AV node? Anwar Zorfi. Okay, Dr. Anwar will explain to us the most important tachycardia we encounter in the EP lab, which is the AV nodal end tachycardia. He will explain to us. Fadal, Dr. Anwar. Anwar, please go ahead.
Hello, Assalamu alaikum. This is the simple anatomy for the right atrium, as we show. This is the inferior vena cava, and this is the superior vena cava, and this is the cross section during LAO view of the right atrium. And as we see here, this is the ostium of the coronary sinus, and this is the compact AV node. In the background of the physiology of the AV node, in patient with AVNRT or even in the patient without AVNRT may be dual AV nodal physiology. The dual AV nodal physiology meaning there is two pathways. This is the fast pathway and this is the slow pathway. And this fast pathway and the CS ostium in addition to the slow pathway and the compact AV node, meaning all these structures composed of triangle of two. So in the AVNRT, mandatory to learn or to understand the triangle of two that compose of all these structures. This side is the ablation side of the slow pathway. In the mechanism of the AVNRT, this is the sinus rhythm, and each beat from the sinus node will go to the fast pathway and then to the ventricle, and this is the ventricle signal. When there is BAC that coming at the time in which the fast pathway was refracted and the slow pathway not refracted, will become and return again in the fast pathway, okay, and then conduct to the atrium and ventricle at the same time, and it created the re-entry tachycardia. Again, the sinus rhythm normally conduct through the fast pathway, and even the patient have dual AV nodal physiology. The conducted beat will be partially conducted on the slow pathway and completely conducted on the fast pathway. Really, in the fast pathway, there is retrograde conduction on the slow pathway. So this signal will be attacked on the same signal coming from the integrate bar, and the colloid will be occurred in the slow pathway. So nothing happened in the patient and nothing appeared in the ECG. But when the BAC coming at the time, just at the time when the fast pathway was refractory and the slow pathway without any refractiveness. So the signal will coming in the slow pathway and then return to the fast pathway and create the re-entry circuit, which is junctional tachycardia. Any question, bro? Or any more explanation?
Thank you very much, Dr. Anwar, for the anatomy and explanation. I wish that we stimulated the fellows to go and read about AV node re-entry tachycardia, because it is more than 50% of the work, of the daily work at the cath lab, at the EP lab, is AV node re-entry tachycardia. So you have go read it and enjoy it.